pause.
Is that sure? Hello, everyone. Welcome and thank you for joining us tonight. On behalf of MLI, thank you for attending this symposium entitled Nursing Perspectives in Myelodysplastic Syndromes, Risk-Adapted Therapy and Symptom Management. This activity is supported by an educational grant from Bristol-Myers Squibb and Geron Corporation. I just want to start by saying, unlike other talks you may have listened to, we really want your involvement today, and that's why we're sitting here in a casual way. And we want you guys to be involved and have a didactic discussion so we can all learn from each other. I'm Eileen Galinsky. I'm a nurse practitioner at the Dana-Farber Cancer Institute, the Adult Leukemia Program. And I wanted to introduce Christy.
Hi there. My name's Christy Orbaugh, and I'm an adult nurse practitioner at Community Hospital Oncology Physicians. We are a large community practice, so I always want to be real transparent. I don't just see hematology like my esteemed colleagues, but I am in community practice, and we do see a fair amount of MDS.
Hello, everyone. I almost said good morning, but good evening. I'm Selena Carmona. I work at MD Anderson Cancer Center in Houston. I work strictly in adult leukemia. I'm a PA also. So yeah, we have a good group of APPs that work in very similar patient populations, but also from a different perspective as well.
Just got some housekeeping stuff I have to go through, so there is us. As I mentioned, it's going to be a different type of presentation, very didactic. It's a 90-minute presentation of questions, discussions, etc. And we hope to accomplish this today by using the audience response. I hope you guys zapped your phone. We have patient cases. We also have one of Selena's patient who's going to be talking by computer or whatever, not live. And then we're going to have some open discussion. The agenda, we have 4 modules set up. Module 1 is understanding risk stratification in MDS from diagnosis to prognosis. Module 2 is managing anemia in low-risk MDS from ESAs to targeted agents, navigating an evolving treatment landscape. Module 3 is monitoring and managing adverse events, anticipate, recognize, and respond, the nurse's central role. Module 4 is nursing-led education and shared decision-making, empowering patients to be active partners in their care. And then we'll end with conclusions and question and answers. In your handouts, you have the learning objectives, so I'm not going to waste time reading them. Again, this is sponsored by MLI. You are going to see any credits, and at the end we'll have the link posted for you. We're going to have polling questions pre and post. We're also going to have in front of you, you should have some papers to write notes. If you don't feel comfortable raising your hand, people will be bringing them up to us. If you do feel comfortable, someone can bring a microphone as well. And all 3 of us are fine with you guys interrupting us if something comes up. Like I said, we really want you to be involved in this discussion. So without further ado, let's get started. We already said that. Just wanted, here are our disclosures and the planning committee's disclosure and our patient's disclosure, just so you're all aware. And now I would like to hand it over to Selena to kick us off today.
Okay, guys. So for Module 1, we're going to talk a little bit about MDS, a little bit of basics, and then talking about risk stratification before we transition into treatment and management. Okay, so this statement, I want to kind of start off with this because I think this statement, which reads, I am classified as low-risk MDS, refractory anemia with ring sideroblasts. And I know that statement is very loaded for such a small sentence, but I think it's very important because we're going to be talking about each component specifically, and then by the end, this in and of itself will be able to address from different perspectives and in terms of a team management and taking patients, of course, always into consideration. So I think it's like I said, for such a short sentence, it's very loaded, but we'll be going into all of it.
Selena, can I just take a second in the audience? I meant to ask, I didn't mean to interrupt. How many of you are inpatient versus outpatient? And just by a show of hands, how many are inpatient? And the rest are outpatient? And your exposure to patients with myelodysplastic syndrome? Great.
Awesome.
I was interested, do any of you just see heme? Okay.
Okay. Awesome. A good crowd. Okay, guys. Again, like Eileen was saying, I know all of you saw your QR code, so I just want to give a few seconds for those of you who haven't. You can go ahead and use your phone, get the QR code set up. Like I said, we'll be doing pre and post questions, get your insight, things like that. And again, please stop us if any questions, concerns, anything that you guys would like to say. Yes, please. That is a question I don't know the answer to. MLI 26. Great question. That's a good way to start. I love it.
One that we couldn't answer.
Yes, one that I cannot answer. Okay. First question is a good icebreaker question. Which San Antonio experience would you choose first? You have strolling the Riverwalk, visiting the Alamo, eating authentic Texas barbecue or tacos, and catching a live music show. I grew up in San Antonio, so I'm always going to go with C. What about you guys?
I like to eat, yeah. I'm going with C as well.
Food is number one.
That's very true.
Where's a good barbecue?
Oh, Rudy's barbecue is great. I love Rudy's barbecue. Okay. So polling question. This is for you guys. We really want to get your input. In your practice, how confident do you feel discussing MDS risk stratification with patients and families? We have very confident, or you regularly explain risk scores, somewhat confident, you understand the basics, not very confident, I rely on the physician's explanation, or not at all confident. This is an area in which I would like to improve. Okay, yeah, I feel like we got a good mix of everything, so well, our hope is by the end, we're all feeling very confident and able to learn from each other. Okay, pre-test question, not to quiz you while you're eating dinner, but which mutation is most commonly associated with the presence of ring sideroblasts in low-risk MDS? A, ASXL1, B, SF3B1, C, TP53, and D, U2AF1. I really want to encourage.
And don't worry if you don't know.
Yes, it's anonymous. We really just want to get your input, like I said, your interactions, so please go ahead and answer, guys. Okay, give a few more seconds. Okay. Another test question. Which of the following best describes the primary advantage of the Molecular International Prognostic Scoring System, quite a tongue twister, or IPSSM, over the revised International Prognostic Scoring System, IPSSR, in patients with MDS? It eliminates the need for bone marrow biopsy at diagnosis. B, it incorporates somatic gene mutation data to refine prognostic risk categorization. C, it is the only scoring system validated for use in high-risk MDS or HR-MDS. Or D, it replaces cytogenetic analysis as the standard diagnostic test for MDS. I was going to say, where's the Jeopardy background music? And again, these are questions that we'll go over the answers in a bit. have a little more time. Whatever you guys think, we just really want to hear from you guys. A few more seconds. Awesome. Okay. So lucky winner time. First we're going to quiz you, and now we're going to give you guys gifts. Please check around your seat for a yellow smiley face sticker to see if you've won the water bottle. I don't think we were candidates. Oh, awesome. Winner, winner, chicken dinner.
Yay!
Yay!
Is it only one water bottle?
Yeah.
One?
Yeah.
Okay. And Alexa, you saw who the raised? Okay, perfect. Congratulations.
Yeah.
You're our first winner of the night. Okay. So going into a patient case. So this is Margaret, a lovely patient with MDS. She's 72 years old. She came in diagnosed with low-risk MDS, an SF3B1 mutation, quite anemic, requiring blood transfusions. She came into the visit with the following statement. I keep telling my doctor I was tired, not just normal tired, the kind of tired where getting dressed felt like running a marathon. I had no idea what MDS even was until they told me my bone marrow was the problem. And I imagine this is a very common statement, or variations of this statement that we all hear, and I imagine you guys do as well. So we'll kind of be diving into this a little bit. Panel discussion. So like I said, this is the part where we're going to talk amongst ourselves, but we really want to hear from you guys too. If you have any questions, please raise your hand. What questions do your patients ask first when they first hear the term myelodysplastic syndrome?
What is it?
Yes. I think I always hear, is it a leukemia, since it's not in the name?
Just the term sounds scary.
Is it a cancer?
Is it something that I did that caused this? Why did this happen? Variations of that.
And another thing I get asked a lot, and you mentioned it, is this going to turn into acute leukemia?
Yeah.
I guess thinking of something else I do always hear, how will this affect my family, my children, my siblings, things like that.
Sometimes the first, or a very early question too, is, can you fix this? Can you cure me? You know.
What is the treatment? How will it
Right.
affect my day-to-day life?
I've got this, now do something about it and make it better.
I agree. Okay. Anything else that you guys want to contribute as well? Any ideas on your end? Yeah.
Yeah.
She said, is it curative? The outlook, like the long-term prognosis. Very much so. Anyone?
How do you guys respond when someone asks you a question like that?
Yeah. Right. Yeah.
No, it's okay. It's not easy for even us when, you know, obviously we're not God, right? And then we start going into the normal, the trajectory, and we try to put it all together. And as you're gonna hear, Selena's gonna talk more about what the risks are and how to treat those risks.
A very loaded question, very much so for our patients and their families. Anyone else before we move on? Okay. So MDS at a glance. So it's of course very difficult to make one, you know, just a few slides on what is MDS. But at the basis of it is abnormal stem cells. Of course, you have hematopoiesis, and how I describe to my patients is stem cells being these pesky little teenager cells that don't function like we need them to. You know, our teenagers, they're a little finicky and they don't work like we need them to sometimes. So as a result, this hematopoietic process doesn't function, and therefore, as a result, the white count, the hemoglobin, the platelets, to a certain extent, are affected, right? So when they're affected in that way, it leads to cytopenias. And I think you guys can speak to that, of course, as well, that patients present in a very different manner, whether that be variations of extreme anemia requiring transfusions, a low white count, a low platelet count, 2 of them being low, all of them being low, and to varying extents. But the baseline of it is an abnormal CBC, and you just don't feel like yourself. You feel really horrible. As the main symptoms, of course, we want to make note: fatigue, infections of a low white count, nosebleeds that just won't stop, things like that. There is a risk of progression to AML, acute myeloid leukemia, because the disease itself is very heterogeneous. The risk of transforming into AML is also heterogeneous in and of itself. So I think that's also important for RN to talk to patients about, that there is that risk, especially if you're talking to a low risk MDS patient where that transformation is much lower. But I think it's something that's important to make note of, that I imagine you guys will talk to your patients about as well. There are approximately 20,000 new US cases per year. The median age is greater than 65, so typically patients that are older. Of course, we do see ones that are younger, but on average older. And greater than 60% present with significant amount of anemia. I think that, which we'll want to dive into a little bit more, but that fatigue that they feel as a result is quite debilitating. Okay, so in the bone marrow biopsy, something we want to make note of is ring sideroblasts. I know that's a term that we've all heard quite often, and it's associated with very refractory anemia. And I like this picture a lot. What it does is it shows us what are ring sideroblasts. So we have these baby red blood cells, your erythroid precursors in the marrow, and they have this literal, I wish I had a red pointer I could point at. These literal, where you can see the arrows, these rings that are around the cells, and they can have this nucleoli that are comma shaped, just very funky. But when it's shown on the pathology, it'll come out with a percentage of ring sideroblasts associated with the MDS. So we always make note to see the extent of that in patients with significant anemia.
Selena, may I ask, can you explain the importance of obtaining a bone marrow aspirate and biopsy in this patient population?
I will. So how I like to, I always go back to how I would explain it to my patients. I always tell them that a CBC is a peek in the window of what's going on, like a peek in the window of a house. But you don't buy a house by just looking in the window, right? You need to get in there, poke around, have someone who's more qualified than you are get in there and tell you what's going on. So to do that, you need to get inside. And if a CBC is abnormal, then unfortunately, the only way to figure out what's going on is to get inside the bone marrow, right? Like the factory of these cells. And so, after ruling out any other acute causes of significant anemia that any medical team would do, going into the factory and really figuring out why the CBC is so abnormal is the basis of what we would do from a leukemia perspective. You would agree? Anything you guys want to add?
I use the factory
Yeah,
analogy
the
as
factory.
well.
Yeah, it's a good analogy.
Yeah.
Okay, so diving into more of the bone marrow. So you have your pathology reading, right? You're looking at for a formal MDS diagnosis. You want to talk about the blasts, these pesky teenager cells that aren't functioning like we need them to, less than 5% being normal. Are they elevated? Are they still normal but not functioning? What that looks like. And then the next step is chromosome analysis. So are there any abnormal chromosomes, right? And I always make a point to say the chromosomes in the bone marrow being abnormal, because I think patients hear chromosomes and they think inherited. So the chromosomes in the cells in the bone marrow are abnormal, and then we put them into these categories. You have very good, intermediate, poor, and very poor. So it splits them, of course, anything normal or minus Y, which is very common in elderly gentlemen. Anything on the 5th chromosome, anything on chromosome 17 tends to be a little bit pesky, and then anything with a lot of abnormalities in the chromosomes just tends to be a little more stubborn. So from an MDS, it puts it into these nice little categories. And then the last thing that we will look at, like I said, pathology, blast percentage, chromosome analysis, and then the mutation analysis, a newer test, very useful, that we'll dive into a little bit more. But I liked this chart from a paper that I read quite often in terms of the mutations and their frequency in MDS, and the ones that are very common. So we want to make note, of course, with SF3B1, a very common low-risk MDS mutation that we will see. But I think I like it because it compares the mutations you can see in low risk, intermediate, and high risk MDS, among others, and the frequency of them. So SF3B1 itself is actually mutated in greater than 80% of cases with MDS, so quite a significant amount. And they're also correlative with ring sideroblasts as well, that nice little ring that we see in the cells. So I like to tell patients they're like Siamese twins a little. They kind of go hand in hand. So we do see them quite often together. SF3B1 itself is a founder mutation in MDS, but it does, just because it's correlative with ring sideroblast doesn't mean that they always go together. You can have SF3B1 on its own, but not note any of those little rings in the cells. But a very, very common mutation in low-risk MDS in a patient presenting with significant anemia. Okay, so going into risk stratification, you have the IPSS-R versus the IPSS-M, two different, very similar in terms of calculating this risk. And I always tell our patients that when we think of cancer, we think of stage 1, 2, 3, 4, but it's not necessarily applicable for leukemias. Instead, we do low risk, intermediate risk, and high risk, and then the gradient that is kind of in between. So for IPSS-R, what it takes into consideration is the age, the cytogenetics, those chromosome abnormalities, and if they're good, very poor, et cetera. How their CBC looks is a really impactful one. And then from there, it pops out all these very terrifying numbers in terms of risk and risk of transforming into AML, risk, 5-year survival, et cetera. IPSS-M actually incorporates the gene mutations. So the next-gen sequencing, all those mutations that we'll test for. And I think I know the slide says 31, but I was hoping to get you guys' input because I feel like what I see since I see a lot of patients that come from other hospitals or have bone marrows done at other institutions, which I'm sure we all will see, how the number of mutations, the number of genes that are tested kind of vary. So I was hoping to see from a community perspective, and then of course at Dana-Farber, what you guys experience, and then of course you guys as well in terms of the panel that you test.
You go first.
We usually just see the 31 is what I typically see.
Do you send it out or do you do it locally?
We do it locally, but one thing I should have said is I am community practice, but we also are a partner of MD Anderson, so they also help guide us.
Got it, perfect. So at an academic center like the Dana-Farber, we have quite a significant sequencing panel. So majority of times, if we get referred a patient that already had a marrow, we usually repeat it, either for clinical trial or to gather more information because we don't have the complete picture. And as you mentioned, in addition to help guide the therapeutic option of what is the likelihood of you progressing, it also dictates what treatment.
Right.
And the only known cure, which I'll talk about, is the stem cell transplant. Not an option for, it's kind of questionable because you mentioned MDS is more common in the elderly. We know stem cell transplant's the only known cure. Yes, everyone's moving the age of transplant. Right. But in reality, how many people with MDS in the older population are going to get transplanted? Correct. So that leads to the discussion of other potential treatment options.
Yeah, I agree. But from MD Anderson perspective, we run a full 81 gene panel, possibly not every time, but we do have that 81 gene panel. But yeah, it's interesting how that differs a little bit between institutions. So I thought wanted to make note of that. So the IPSS-M, the key genes it makes note of course, are the SF3B1, RUNX1, typical MDS mutations, ASXL1, of course TP53, that being a little bit more of a stubborn gene mutation in all cancers. But whenever now we're taking into consideration the mutations, it would change the overall picture in terms of risk. So you have a patient with overall normal, okay CBC, but then they have 4 or 5 mutations. When we take that into consideration, it kind of changes the overall, which I know Eileen will talk about, approach in terms of care, because it could make things a little more complicated in a deep molecular level. So it's a more precise, and it really does change whenever you compare it on the calculator, the risk, it really does change our approach to care, because it really adjusts the low, intermediate versus high risk MDS. Something we want to make note of course, is some more favorable characteristics of MDS. Of course, we talked about the SF3B1 with the ring sideroblast, very favorable. We have deletion of 5q, RUNX1, a TP53, and a complex karyotype, meaning 3 or more chromosome abnormalities tend to be a little more stubborn or high risk. And then the other very common, especially causing anemia, mutations are TET2 and DNMT3A. So very typical MDS mutations.
Mm-hmm.
Okay, polling time. I know everyone got the QR code. Okay, at your institution, is NGS or next generation sequencing routinely ordered at an MDS diagnosis? So that mutation panel that we talked about. Mm-hmm. We'd love to hear from you guys. Quite a few people do to varying extents, but it seems like this is overall routine testing for most institutions. Okay, we go back to Margaret, our lovely 72-year-old female patient with MDS. She had fatigue for greater than 6 months. She is quite anemic, hemoglobin 7.8, platelets are 110, ANC, or her absolute neutrophil count is 1.4. Her bone marrow showed 4% blasts, so normal amount, but she did have those ring sideroblasts and an SF3B1 mutation, and the deletion 5q in her karyotype in her chromosome analysis. She was classified as low risk MDS with the IPSSR, but when we incorporated the IPSSM, it reclassified her to intermediate. So kind of further proof about how that kind of changes the risk when we add in those little pesky mutations.
Mm-hmm. And it helps drive therapy.
Very much so. And overall, especially for long-term therapy, or kind of I even going into transplant and whether it's needed. So panel discussion, how does the molecular reclassification change your nursing assessment and patient education approach?
Well, just as I said, it's definitely going to help drive the treatment decision. And depending on the treatment that as nurses, then this treatment will cause these side effects, this treatment will cause that, so it really helps us educate the patient on what to expect, what might come next, mm-hmm. and what comes next after that.
So I think I agree 100% as a clinician. It helps us in what we are going to do to the patient. I have clearly seen over the years, knowing this information adds another level of stress and anxiety mm-hmm. to the patient.
Yeah.
They are obsessed with their mutational status, and if you ever recheck or doing another bone marrow and the mutations change or their VAF goes down or goes up, they're really freaking out about it. So there's another level of discussion.
Yeah.
That adds.
Well, and frequently they will discuss their mutation with Dr. Google before they talk to you.
Or Mr. Chat GPT.
Yeah, oh, I forgot about Mr. Chat, yes. And then they come in scared to death.
Exactly.
And and I think also it can be confusing for patients who have, let's say, a normal or overall, maybe mildly anemic, but otherwise a CBC that looks okay,
right.
But they have 4 or 5 mutations, and it's confusing why we're being a little more aggressive. I don't say aggressive, but more, I guess, intentional in terms of our therapy and our treatment decision, and talking about something scary like stem cell transplant when they're overall, they feel fatigued, but overall like themselves. So I think that's also, it's a little bit conflicting and confusing.
Do you guys, in your practice, and I know everyone does something different, have patients been more verbal in discussing with you their mutations or what the clinician had told them about their treatment or their prognosis? Has that changed in your practice at all? Nothing?
I saw a few heads shake.
Yeah. Yeah, I imagine it's, I guess, yeah, changed the care a little. The patient population?
Like older patients seem so overwhelmed by the information they're
Yeah,
given.
very much
Maybe
so.
their level of education too might play a role in that as well. But if they already have like some type of mental, like altered mentation, like confusion that's already starting, like once they start hearing all these other things, then it
Overwhelming and then to
over their head.
shut down a little?
Yeah.
Yeah, I can definitely understand that. Thank you for your input. I appreciate that. Okay. Okay, guys, we'll keep moving along. What does Margaret most need to understand about her prognosis right now, and what would you document as nursing priorities at this visit?
Well, I think she needs to understand it's a chronic disease.
Mm-hmm.
And that she's going to most likely be in some sort of treatment moving forward.
And that it's not just her anemia, which would explain why she's so fatigued, but her white count is also low. Her platelets are also trending down, so it's a little bit multifactorial, which I think is also tricky.
Yeah, and I agree. I mean, I think from a nursing standpoint, the role would be to support, explain, and educate, and I think emphasize that there are therapies that can help her feel better and some directed therapies that could potentially be used for her.
Yeah, I agree.
Hello, my name is Linda Deanda.
Oh, I apologize. We're going right into Miss Linda and her is a patient with low-risk MDS and her viewpoint and her experience with this diagnosis. I am sorry, guys.
Hello, my name is Linda Deanda. I'm 54 years old, and I was diagnosed with MDS in June of 2025. My nurses at MD Anderson have been great, but the person who really came in and explained everything to me was my PA, Selena Carmona.
Oh,
She is
oh
absolutely
gosh,
wonderful.
I haven't watched this before. I'm sorry,
She
guys.
knows MDS front and backwards. She came in after my bone marrow and she drew me a chart. It's an extremely detailed chart from the very beginning of what happens in my body, what's happening in my body, and how it's going to affect me long term. I'm in the lower MDS now, but how it could progress. She did a phenomenal job. She put me at ease. She showed me that there were treatment options. Dr. Borthakar came in and let me know that there was a research drug that could help me. And so it was smooth sailing after that.
So nice of her. So this is what this is what I draw. I like to draw out for my patients whenever I see not just MDS but really any leukemia patient. I always start and I always ask if anybody in the room is in medicine. I always like to ask that, and I kind of always go basics. What is the bone marrow? This is what we look at without making it too overwhelming. What causes MDS, very common causes, and then I go into the bone marrow, talk a little bit about what we will look at every time so that whenever they do have a bone marrow and they get these very overwhelming results in their MyChart or whatever electronic medical system you guys use, it's very overwhelming. So just to kind of break it down and know that this is what we'll look at every time, and then how that correlates with their bone marrows that they've had done, especially for a new patient visit, and how we'll address that. And there's my little, I think that's my ring sideroblast little drawing on the right. And then I go into the IPSS scoring and take into the mutations into consideration, talk about the risk, and then how we would address someone like Miss Linda, where we think she has just low risk MDS. I tend, of course, not to focus on the really intense portions where it can be very overwhelming, but really talking about the symptom management and the treatment options we would have for her. And then I think breaking it down with different colors also helps kind of focus the brain a little when so much information, there's so much going on. And I think it's also important to know that we're going to see the MDS unless we do a stem cell transplant, which I think the expectation of it going away and curing it like you would a bacterial infection is hopeful, but really making sure that that's understood as well. Okay, post-test time. We're gonna quiz you guys again. Oh, I apologize. I'll give you guys a few more seconds. I went too fast. Okay. And it's also on your tables, I believe, as well. Okay. So post-test, which mutation, again, is commonly associated with the presence of ring sideroblasts in low-risk MDS? So we have the ASXL1, SF3B1, the 53, and the U2AF1. So the correct answer for this is SF3B1 mutation, most commonly present with ring sideroblasts in low-risk MDS, A+. The second question is, which of the following best describes the primary advantage of the IPSSM over the IPSSR in patients with MDS? We have eliminates the need for bone marrow, incorporates somatic gene mutation to define prognostic risk categorization, the only scoring system validated for high-risk MDS, and it replaces cytogenetic analysis. Answer to this is B. It incorporates somatic gene mutation data, defines prognostic risk categorization.
Good job.
A+. Okay, we have lucky winter time. I get to give all the gifts to everyone. Please check around your seat for a blue smiley face sticker. You want a Scrubs gift card. Woohoo. Good job. Congratulations. Okay, so I'm going to pass it over to Eileen so she can keep teaching us.
Okay, so I'm going to discuss treatment of low-risk MDS, beginning with ESAs and new targeted agents, and how it has changed over the years. So one of the major issues with low-risk MDS, as Selena mentioned, is people are red blood cell transfusion dependent. This can be costly to the patient, to the hospital, the effect on the patient, the family coming in for transfusions. And as we mentioned, I'll talk more about, is this terminology of overwhelming fatigue that may go along with the MDS, may go along with the anemia, that this can really change people's lives. Like we say, oh, you have low-risk MDS, so what, you need transfusions. But it's really important to recognize how that impacts the patient sitting in front of you. So as you can imagine, if someone is used to coming in every week, every 2 weeks to get a unit or two of blood, that's taking its toll, it's affecting their quality of life. So if someone can feel better and also decrease their need to come into the infusion room, we've done a really good thing for this person. And I'm going to talk more about that. Do you agree that in your practice, that's what people complain about?
Yes.
Oh, mm-hmm.
As amazing as our infusion nurses are, our patients want to start seeing other people at some point.
Yeah, they usually say, we love to see you, but we don't want to see you anymore.
Right.
I'm like, I don't want to see you either. I don't want you to need us.
So, okay, we're going to pre-test time, okay? All right, so which of the following is indicated for patients with low-risk MDS and transfusion-dependent anemia after they have failed ESAs? A, azacitidine, B, decitabine, C, imetelstat, D, lenalidomide. Okay, next question. A 69-year-old woman with low-risk ESA naive, transfusion-dependent MDS, they receive 4 units of blood in an 8-week time frame. Hemoglobin is 7.8. They get started on luspatercept at a dose of 1.0 milligrams per kilogram every 3 weeks. After 6 weeks, she has no transfusion independence, and she has barely had an increase in her hemoglobin. What is the best next step to manage her anemia? A, add an ESA concurrently while keeping luspatercept at 1.0 milligrams per kilogram. B, increase luspatercept since hemoglobin remains below the 10 to 12 target after 2 doses at the same level. C, stop luspatercept and refer for immediate transfusions. And D, switch immediately to an ESA since luspatercept is ineffective at 1.0 milligrams per kilogram. Okay, so, I don't know why it's on, oh, there we go. Okay, so the real burden of MDS-related anemias, I just briefly touched on, and Selena mentioned it too. So most of these patients get diagnosed because they aren't feeling well. They're fatigued, they're short of breath, they may have some bruising, etc. And once you got to work up to make sure they're not bleeding, they don't have a thyroid problem, but they're still fatigued. And they come to our clinic, and again, we do their bone marrow and we say they have MDS. And I just want to really drive home that this fatigue is not just being tired. Mm-hmm. It affects them not only physically, cognitively, emotionally, and functionally. I have this patient that just could not get out of bed. She was a very active woman and just could not get out of bed. And the transfusions didn't help, and she just was like, I can't live like this anymore. So have you guys heard your patients express to you about this overwhelming fatigue? And you guys?
Absolutely. Mm-hmm. Absolutely.
So how I look at the symptoms of how to treat low-risk MDS is they can have either 1, 2, or 3 cell lines affected, okay? If they have low blood count, they are risk for infection. Some people use growth factors. Some people put patients on prophylactic antibiotics. For thrombocytopenia, some people try to treat it with M-plate or Promacta. I'm going to focus tonight mostly on how to make the anemia better. And in 2026, unlike if I did this talk 6 years ago, we would have very limited options to discuss with you. Today, we have ESAs, we have luspatercept, imetelstat, and lenalidomide. In all my discussion, just so you know, supportive care with transfusions, growth factors, antibiotics is a continuum. We don't stop one because we're doing something else. So for the fatigue portion of it, and again, you want to figure out what is the cause. So you look at testosterone level, thyroid, et cetera. Some people, if all that's normal, will try physical therapy. You can monitor B12, et cetera. Again, infection, I think prophylactic antibiotics and growth factor in this population, I think, is very dependent on where you work and what part of the United States that you live in. The general body aches, I think we all have our own anecdotal ways of trying to make this better. I do have a question for you guys. We don't prophylact with antibiotics for this population. We don't use growth factor either for white blood cells or platelets in this population. Do you all?
We don't either, unless there's some extenuating circumstance, but no.
I would say we do. So of course, depending on their history, if they have recurrent shingles or terrible mouth sores, we're more prone, of course, to treating with antivirals. But I would say, for the most part, if their ANC dips, we'll treat with antibiotics and manage with growth factors, or like I said, with Claritin. So we do use GCSF quite a bit along with antibiotics, I would say.
And how about in the audience? Are you guys a mixed bag as well at your sites? Okay. Okay. So how I look as a clinician, how I'm gonna treat my patient. So always it's a decision of the clinician, the patient. It's a group effort on what is important to the patient, where they are in life. You know, again, the majority of these people are older. So what do they want and what's their ultimate priority? So I look, in 2026, we look at, as Selena mentioned, risk-adapted therapy. What is their risk of progressing? Again, focus on the patient. What are their mutations? As some are directed therapies. What are their cytogenetic abnormalities? So for first-line therapy, the standard recommendation is to start with ESAs after you check an EPO level. So if they're below 500, they should respond to ESAs. If they have ring sideroblasts, the recommendation is to start luspatercept instead, and we'll talk about that. If they have 5q minus chromosome abnormalities, you can use lenalidomide. Second line is luspatercept or imetelstat, especially if you have low-risk MDS and are transfusion dependent. In the second line, there's data that shows you could use lenalidomide in non-5q patients, and especially if you're progressing and your counts are changing, maybe having a few more blasts, to add HMA therapy such as azacitidine or decitabine. And just as mentioned, supportive care is throughout the course of therapy. And then the only known cure for MDS is a stem cell transplant. Again, we've upped our age probably to 78 at our institute. You need things to get transplanted. The ability to have one, a donor, you have to be healthy. So I'm not gonna spend much time on that, but when patients ask you, is this therapy gonna cure me? The answer is no. And our goal is to improve their quality of life and keep them from progressing to AML for as long as possible. So just briefly, another way to look at the landscape is the ESAs, and that was the first thing ever approved. Lenalidomide was approved in 2005, and it is approved, as I said, for those with 5Q minus. And as you can see, it has a 56% transfusion independence rate, which is good. Lenalidomide's not an easy drug to take. People can have rashes, you have to be in the REMS system, so for clinicians it's painful. And for patients, they have to do surveys, so there's a lot that goes into that. In 2023, luspatercept got approved for the first line for ESA naive patients. And they looked at transfusion independence after 12 weeks, and 58.5% were transfusion independent after 12 weeks versus 31% that received ESA. The next group of patients are those that started on ESA and either became refractory to it or intolerant to it. And luspatercept in 2020 got approved for such patient population. And as you can see, it too had a 38% transfusion independent rate at 8 weeks versus 13%. It was a placebo, randomized placebo trial. Imetelstat got approved in 2024 for those that are ESA refractory or not eligible to get ESA. It can be used regardless of ring sideroblast status, and it has a 40% transfusion independent rate over 8 weeks. So as you can see, there are therapies that are helping patients with their need for transfusions and with the ultimate goal of feeling better and living their lives. So down and dirty, if you have someone that is symptomatic anemia, the first thing, look at EPO level. If it's less than 500, think about ESA or luspatercept for the patient. If their EPO level's greater than 500, luspatercept or imetelstat. And as we talked about, when all else fails or they progress, hypomethylating agent. Just as a reminder, luspatercept is preferred for low-risk MDS with SF3B1 mutation. Lenalidomide is preferred for 5Q deletion or in later line of therapy, regardless of your 5Q. So what do you need to know about patients on lenalidomide? So first, it's an immunomodulator agent. It's a targeted therapy for those patients with 5Q minus. It enhances erythropoiesis by improving EPO receptor signal integrity, okay? These are the trials that got the drug approved for MDS. I'm sure most of you, if you're not familiar with patients, it's not like 5Q minus is all that common. I'm sure you have experience with the drug from the myeloma population. The key, and Christy will talk more about this, when someone's on lenalidomide is myelosuppression. At least for the first 8 weeks of therapy, you should monitor their CBC, and then every month. And this is the key guide to know. Tell your patient up front, you're gonna start with your dose of 10 milligrams for 21 days out of a 28-day cycle, but nearly everybody gets dose reduced. The other key factor for nurses is lenalidomide predisposes you to DVTs and pulmonary embolism, so be mindful, and most patients will be put on thromboprophylaxis to prevent that from happening, so it's important to educate patients on that. And as I talked about, the REMS tests in pregnancy, this lenalidomide is the niece, so to speak, of thalidomide, and we all know horrible things happen to people that get pregnant on thalidomide. Do you guys use a lot of lenalidomide in your practice?
In this population, with the 5Q minus, yes. I was interested, what do you put them on to prevent clotting?
So we will put them on low DOAG.
Okay.
I would say, yeah, I give quite a bit of lenalidomide to patients. In reality, I have a lot of patients who do lenalidomide and luspatercept, or and an ESA of sorts. We tend to not start them on with the DVT PE risk, but for the most part, I would say patients come in already started on a baby aspirin. So we usually just monitor very closely.
We start them on a baby aspirin. So this is interesting. All three different.
I think the issue, it does vary, right? And then you run the issue. If your patient has 5Q and thrombocytopenia, you have to pick your battle.
Yes.
So for those patients, we would just do a baby aspirin and, educate. So it varies.
I think what we keep hearing, a recurring theme, is we have to remember each patient is individual, and that's how we'll choose their treatment and their supportive care as well.
Even if they have the exact same bone marrow characteristics, the treatment can vary tremendously.
Yes.
Yeah. As I always tell my patients, I'm like, there's 2 of you are not the same, so don't look at like Dr. Google, because as you said, just because someone has the same mutations, it's a very heterogeneous disease, and I think we can't lose sight of that.
Right.
Okay, so luspatercept, all of you are familiar with that in your practice?
Seeing a lot of shakes there.
Okay. So this was a first-in-class erythroid maturation agent, and it's a new mechanism of action for low-risk MDS with related anemia. It promotes late-stage erythroid maturation. It is given subcutaneously every 3 weeks at a starting dose of 1.0 milligrams per kilogram, and based on the CBC, you increase to a max dose of 1.75 milligrams per kilogram. There were 2 key trials that got this drug approved, the Medalist trial and the Commands trial. And what's the take home here is, as you can see, the response rate to transfusion independence at different time points, at 8 weeks and 12 weeks in the upfront setting. So this has been, for a lot of patients, a big win for them. They come in every 3 weeks, and they don't need transfusion. So this has been a win for a lot of patients. However, nothing is for free, and there are quite a few side effects that we have to educate our patients on, such as what we're trying to make better, fatigue and malaise. This is a common side effect associated with luspatercept. Hypertension, so it's important to educate your patients to check their blood pressure, or when you're seeing them in the clinic to notice if their blood pressure is high. It's multiple injections, sub-Q injections, so some people can get site reactions, and patients can become dizzy and lightheaded at times. So these don't happen to everyone, but I think it's important to educate patients so they know what to look out for.
I think we have a question. I'm sorry, I'm gonna interrupt.
So I had a patient who I started her on this medicine, and I believe her hemoglobin was about an 8 when I started her on it. And within 5 days, her blood pressure was like 210 over 110, like super high. Ended up having to be admitted because we couldn't get her blood pressure under control. And her hemoglobin shot up to 13. Now the patient is refusing to go on the medicine at all. So, and I was like, well, let's watch you and see what your counts look like, and we'll have to revisit it maybe down the road. But she's absolutely, so is it a contraindication to restart her on it because she had such a high, blood pressure? When you read the, drug
Package insert.
Yeah, Patrick, yeah. It says basically cut, go down. But like, what would you do in this situation is my question.
So I assume she had normal blood pressure and was not on antihypertensives before.
She was on antihypertension, but she had a normal, her baseline was fine. Yeah,
Was well controlled.
well controlled, yeah.
So one thing I would do,
She's also
Is-
86 years old.
yeah, so one thing with her big response, you could argue just not dose her every 3 weeks. So we all talked about this earlier. We have patients that respond very well and do not come in every 3 weeks. So that's another thing, because usually the high blood pressure, in my experience, will settle down. I mean, again, she's 86, you know, we're trying to make her feel better. So if she's not willing to try to increase her hypertensive, or she's just so fearful that it's gonna happen again and she's getting admitted, then I would look for another agent.
Thank you.
Okay. Okay. So there's, just want to talking about package inserts. So there is some guidance now for dosing updates for luspatercept in the first line low risk MDS ESA naive patient population. So the goal is to get your hemoglobin to 10 to 12, okay? And the goal is to give it every 3 weeks, and you start at 1 milligram per kilogram, as we talked about. There's guidelines, as you all know, to increase the dose based on the hemoglobin when they're in your clinic. And then the guidelines to reduce based on your hemoglobin. There's a new criteria that is now in the prescribing manual that if your pre-dose hemoglobin is greater than 12 and you have not received any transfusions, they want you to hold further dosing until it goes below 11 and then resume at the same dose. And the key take home here is to resume at the same dose when you meet criteria to start. They suggest discontinuing if after at least 3 consecutive doses at the higher dose if you have not had a response or you had an unacceptable toxicity. And I think in this case with your patient, especially looking at the individual patient at her age, I wouldn't have it in my heart to challenge her, to be honest. Your thoughts?
If you felt pushed to re-challenge her, this is definitely when I would phone a friend and have cards on board. Right there with us.
Yeah.
Yep. I'm wondering how quickly, if I've never seen that before on a single dose, to essentially overcorrect. I'm wondering how quickly, if she was at 13, how quickly her hemoglobin dropped into the 8s, or if maybe it tend to sit in the 10s and she's still feeling okay and her blood pressure is okay. I know you can give possibly half starting dose of luspatercept, but I would probably, at her age, God bless her, I would probably try to an ESA or something to that extent. So the fear is I would also be a little nervous.
Yeah.
What did you end up doing?
Oh, she came back she was down to like 11 and a half when I saw her, and she was, no, she's like, I don't want it. And that was probably like about 9 to 12 weeks after her initial.
And her blood pressure was normal at that time?
It was normal.
And
yeah.
normalized.
I feel like in the 11s.
Yeah.
Yeah, that's a
Yep.
win.
Met the criteria.
Yeah.
All right. So I want a Matostat, which is a newer drug. This is an IV infusion that is, oh, is there a question?
Yes.
Go
Yeah, I just wanted to clarify like two questions. How does it cause hypertension, and does it have any other cardiotoxic side effects? Is it possible that it's like inhibiting a receptor that's preventing the effects of her actual antihypertensive drugs?
Great question. I'm not sure of the pharmacodynamics myself. It does also can cause potentially kidney issues, so I wonder if it's somehow maybe related to erythropoietin, some mechanism like that, but I personally don't have an answer. I don't know if you guys do.
No, I don't.
I don't know off the top of my head the mechanism of.
But we can clearly find out.
Yes, we could get you a.
That's a great
great
question.
question.
In reality, I don't believe it causes other cardiotoxicities. I think the big one is blood pressure. But I don't know. I don't know the answer to that, actually.
We will look, make sure you give us our stuff and your information, and we can find out and get back to you.
I mean, you feel like it has to be something within the pathway.
That's what I think, yeah.
But
So a Matelstat is given IV, and it's given every 4 weeks at a dose of 7.1 milligrams per kilogram. It got approved in June of 2024 for transfusion-dependent low-risk MDS that were refractory intolerant to ESAs. And the phase 3 EMERGE trial, and maybe some of you participated in it, what showed, which was really exciting, was the transfusion independence lasted and was persistent over time. At 8 weeks, 24 weeks, and at greater than a year, people showed that they had significant decrease in their red blood cell transfusions and becoming transfusion independent. And the key trial data is there to show that it was durable. This also has side effects that we need to educate our patients on. It does cause thrombocytopenia and neutropenia, so we have to be mindful of that. It also can cause liver enzyme abnormalities, so we follow that closely. This too, you have to tweak based on the labs and the patient of holding and reducing dose. And similar to luspatercept, it too temporarily can cause fatigue and muscle aches. So when patients come in addition to looking at their numbers to make sure they qualify to get it, it's important to also ask them how they're feeling and if they're having any side effects.
right.
Okay, so James is a 68-year-old male with low-risk MDS, has ring siderblast, SF3B1 mutation, a hemoglobin of 7.2, a serum EPO level of 420. He requires red blood cell transfusions every 6 weeks. He does not have 5Q minus. His IPSSR score is low. He is now considering treatment options for his anemia. I asked my group, based on this, I'll go to Selena, based on this profile, what would you suggest or discuss with your patient?
I would say we would continue transfusions as needed, and with his EPO level, I would probably start him on EPO, on ESA, see how we do every 2 weeks, and go from there, and give it a little. Of course, the tricky thing is it needs a little bit of time for it to work, which I know is frustrating for them and for us as well. But I think that would be my front line, would be an ESA.
That's what I'd do as well.
Okay. What do you, if you were talking, I'll ask Christy, if you were talking to the patient about luspatercept versus ESA, because you can give luspatercept in the upfront setting in ESA naive patients, how would you coax the discussion?
Well, I think in simple terms, I think I would try to tell them the mechanism of action of the drug. You know, what EPO does and versus what luspatercept does. You know, keeping it simple, but so they understand that there is a difference and different mechanism of action. I think that's where I'd start.
Agreed. And then how much the wallet biopsy plays a part in people's decisions. As you know, all these drugs are expensive. They're given in the infusion room. We all need like prior auth, and we have a high-cost drug ordering system here that if a drug is in the high-cost category, you have to get it approved.
Right.
Does that play a part in your decision-making when you're with your patient in therapy?
I would have to say it does if insurance is involved, because sometimes you don't have a choice.
And I think that's key for all of us. It's wonderful these drugs are available, but unfortunately, sometimes your hands are tied, that even though you believe it's the best therapy for them, in today's day and age, sometimes you can't give them what you think's the best. And I think that's an added issue. We have to coax how we say to patients, I think, I want you to get this therapy. Sometimes I tell them there's therapy options, but I need to get approval, because I think the worst thing we can do is say to someone, this is what you need, I really want you to have it, and then you can't give it to them because their insurance doesn't cover it or the copay is so much, and I think that's an added issue. I'll let you guys decide. Okay, so just briefly, if we started him on ESA, is there anything special? Okay, got it.
Are these medications given after stem cell transplant, after engraftment? Can it prevent graft failure?
They are not approved at all for that indication. So clearly we don't use them for that at our facility. People, I'm sure, can do things, but I'm not, I have no data, or I'm not familiar with using it post-transplant at all.
Okay.
Just would encourage anybody who's on the fence about taking that drug to do it if they have the MDS, because your quality of life improves so much just by using it. And I have not really had any side effects other than fatigue and every now and then a little bit dizzy. If I stand up a little bit too fast, I may have to stop and just take a break for a couple of seconds and then I can continue. But other than that, I have not had any symptoms. But it has really, really helped me live a better quality of life. I can.
Sorry. I apologize.
Post-test.
Sorry. I cut her off. But due to time, I think I'm going to go to the post questions. Sorry about that. Which of the following is indicated for patients with low-risk MDS and transfusion-dependent anemia after ESA failure? A, azacitidine, B, decitabine, C, imetelstat, D, lenalidomide. Great. Okay. Which of the following is indicated for patients with, did I just do that one?
Yeah.
Did I just do that one?
Yes.
Yes.
Yes, sorry. A 69-year-old woman with low-risk ESA-naive transfusion-dependent MDS starts luspatercept at 1.0 milligrams per kilogram every 3 weeks. After 6 weeks, she has no transfusion independence and has barely increased her hemoglobin. What is the best next step to manage her anemia? A, add an ESA concurrently and keep the same dose. B, increase luspatercept since hemoglobin remains below the 10 to 12 target dose. Stop luspatercept and refer for immediate transfusions. And D, switch immediately to an ESA since luspatercept is ineffective at 1.0. Great. Okay. Just quickly, because we're behind, but I want you guys to get a winner here for a red smiley sticker.
She's got it.
All right. And I want to move, because Christy has a lot to talk about, so I want to move along to module 3 and 4.
I promise, the three of us are committed. We know you all have been in meetings all day. Your feet hurt, your brain hurts. We'll be out of here in 15 minutes, I promise you, okay? So I'm not even gonna belabor this slide much. We've talked about the importance of the fatigue, and I think we all are pretty understanding that it's from the disease. It can also be drug-related. It can be multifactorial, so we need to be respectful of that. We're gonna poll. Get your phones out again. Now, this is actually a word cloud. So what symptoms, and there's not right or wrong, but just type in your phone what symptoms you find most bothersome. Fatigue, shortness of breath. All right. So here's a pretest question. According to updated dosing recommendations for luspatercept in patients with low-risk MDS associated anemia who are ESA naive, how can therapy be restarted after being held for a pre-dose hemoglobin of greater than 12 grams without a transfusion? Restart the therapy at the same dose, restart therapy at the same dose once the hemoglobin stabilizes, restart therapy at a reduced dose once hemoglobin decreases, or restart therapy with gradual dose escalation. All right. So we'll go ahead and move on. We've already kind of covered these, talking about the most common adverse events that we see by treatment, right? So when we're talking about the luspatercept, we've discussed the fatigue, the dizziness. We've also discussed the importance of really watching for hypertension. And I am a firm believer of phoning a friend. You know, we do work in a multidisciplinary environment, and I think we need to work hard at remembering that. Matastat, we've covered nicely, as have lenalidomide. We don't talk a lot about, always talk a lot about transfusion toxicities. Iron overload is an issue, and we'll cover that more in just a bit. Transfusion reactions, volume overload, all of these things can happen. Patients developing antibodies. So transfusions seem simple, but sometimes they can indeed have toxicities themselves or issues. Now, iron overload is a silent toxicity. I'm not going to come to your clinic and say, my heart hurts right now, I think I'm developing iron overload and it's settled in my cardiac cells. I'm not going to say that to you. By the time I have symptoms in my heart or in my liver or in any of my endocrine, there's already significant damage. So what's really important is, as nurses, we need to make sure that we're following that serum ferritin, because every time we give a bag of blood, you're like giving a bag of iron, right? And so really important to remember the milligrams of that iron. If you think they're having cardiac issues, certainly a cardiac MRI T2. There's oral chelation products that will help remove the excess iron, and tracking transfusions. How many transfusions have they had, and what's their ferritin? Making sure that we're following those regularly. Here's Rosa again. Low-risk MDS, times 4 years, transfusion dependent. She's getting a unit 1 to 2 every 3 weeks. She's going to start luspatercept. She's got hypertension, but it's controlled, okay? She also has chronic kidney disease at a stage 2. At 3 weeks, at her 3-week visit, hemoglobin 8.1, blood pressure's up a bit, and patient complains of dizziness and mild fatigue. So again, for the sake of time, we won't go through this because I think we've hit most of this. We're going to be watching her blood pressure. We're going to watch her kidney function as well. And her kidney function probably could have a part in her hypertension pre-treatment. And making sure that she knows when to call and what symptoms to call with, I think. Or did I miss any?
No.
Nope, you covered.
I agree.
I actually love this slide because it's so nursing oriented. And regardless of if we're talking about MDS, whatever disease we're talking about that we deal with all the time, it's so important that we're doing education for patients. And education is not a one and done. Every single time they're coming in, we need to be reviewing things with them. So first of all, we need to anticipate the most common toxicities and make sure that we alert the patient and their support team of those. Every single time they come in, we need to be assessing and be prepared to act, making sure that we either escalate a protocol or we have standing orders or we have some sort of solution or a next step if they have a toxicity, and then re-educating every single time.
I would say
they see
that
them.
my symptoms, the worst one that I have is fatigue. I will notice if I am in a grocery store and I've been there for about an hour, I start getting tired. I might start getting a little clammy. I know it's time that I need to either stop, sit down, rest for a little bit, or I need to get home because I've exhausted myself. Usually it takes a good hour for that to happen to me. I'm lucky. I still drive. I work full time. I have some bruising. I bruise very easily, so I have to be real careful what I'm doing, what I'm lifting. I wish that every nurse would be able to know that, fatigue has such a big part to do with this disease. Fatigue can come across in many ways. It can come across as sad or angry, mad, only because you're mad at yourself because you can't do everything that you used to be able to do.
She's articulate.
Yeah.
I know, breaks your heart.
That hurts me inside.
So how can oncology nursing professionals contribute to watching for signs and symptoms of progression? Any examples of successful multidisciplinary collaboration you guys can shout out quickly?
Yeah, I think some of my patients, I don't see them at every visit of when they're due. I have parameters. I rely on my infusion room nurse colleagues to reach out to me to say they're not doing well or they're not feeling well, so then I can see them and intervene. So I think that communication and knowing what they're doing, the nurses actually giving the drug, their assessment is so important.
And so many times they tell the nurses many more things than they tell the
us.
providers.
Yeah. I would
Anything?
say more often than not at MD Anderson, I very rarely see patients from Houston in and of itself, and they live all over the country, all over the world. So I think collaborating with local teams, I think, is very important, and sharing labs, because if they start to feel worse, more often than not, their CBC reflects that. So I think just really collaborating with other teams and watching labs very closely and being very quick to act if there's a change.
All right. Post-test time?
Just quiz you guys all night.
I know, I know. I am the only one of these that don't have a gift for you, so you can have my half. Okay, post-test question. According to the updated dosing recommendations, remember Eileen talked about this a lot, for luspatercept in patients with low-risk MDS-associated anemia who are ESA naive, when and how can therapy be restarted after being held for a pre-dose hemoglobin of 12 or greater? I'm not going to read all the things just for time, so just go ahead and
I think this song is going to live rent-free in my head.
I know it is. Okay, so what we're going to do is we're going to hold and then restart the therapy at the same dose once the hemoglobin is below 11, okay? Another post question. 73-year-old, oh, I think I accidentally skipped this one maybe. I apologize. So 73-year-old patient, I was clicking happy. Low-risk MDS, transfusion dependent on imetelstat, shows liver function enzymes have elevated after 3 cycles. No jaundice, right upper quadrant pain, or anything else unusual. Total bilirubin is normal. You're preparing the patient for the next scheduled infusion. What should you do? Okay? Proceed with the scheduled infusion, document the lab findings in the medical record, hold the infusion, notify the provider of abnormal liver enzymes and anticipate an order to resume at a reduced dose, administer corticosteroids as prescribed, and proceed with the infusion. Inform the patient the imetelstat will be permanently discontinued and initiate transition to supportive care. Got that right. Okay, so quickly, let's talk a bit about nursing-led education and shared decision-making. Over and over and over again at this entire conference, not just tonight, we have heard how important nursing is. You know, what an inspiration they were, how nurses encourage patients, and how nurses really advocate for our patients. And when we are talking about shared decision-making, we're gonna do a pre-test again here. I think this is one area that we really shine in. So pre-test question, everyone have their little scan. 55-year-old man with low-risk MDS, anemia, and residual thrombocytopenia from prior treatment. He wants to minimize time away from work, but is worried about fatigue. Which strategy best demonstrates shared decision-making? Okay. I'm not going to read those for the... go on, just for the sake of time. So what do patients actually need to know? What do they want to know? So what is MDS? We talked about that earlier. Why this treatment? You know, I've been on Facebook, my Facebook chat group, and Joe Blow is not getting what I'm getting. Why is he getting something different? So why, and we talked a lot about really individualizing that treatment. What does my schedule look like? And more importantly, what schedule works best for me? Do I put it on my phone? Is it a written out calendar? What works best for me, or for the patient, I should say? When should they call? What number should they use? We do my chart, and we are forever coming in on Monday morning and getting like these really significant, or not complaints, but patient symptoms that they send in on Saturday at 3 p.m. You know, no one's watching those. So what do they do in those times when they need to report what's going on? Who's on their team? And what can patients do? What can they control? There's so much about this disease they cannot control. What do they have control over in terms of good nutrition, increasing activity, good sleep hygiene? All of those things are very important. Talking about our approach to patient education, anything quickly you want to say?
Sure, I think the big thing is once you hit refractory or intolerant, I know a lot of times we go in and say the word failure, which I hate that we use that in this case, but it changes, I think, a little bit, saying let's try this that first time, let's try this, and then we'll cross that bridge when we get there. Now we need to talk about a few other therapies that kind of broaden the scope of things and can be a little more complicated. So I think just the approach, the tenderness that comes with that is important.
Yeah, I was just going to say it's always in how you say something, and I think always never giving up hope in the way you say something, as Selena said. You don't say failure.
Yeah, no.
Absolutely.
I really
They
don't like
didn't fail.
that. Yeah, I hate
That's always
really
so
hate
important.
how it puts it like that.
All right, so just to discuss shared decision making, remember we all have priorities, we all have preferences, and patients have priorities and preferences as well. And that's the key to shared decision making, understanding that patient, really leaning in and hearing what they're saying, what's important to them. Right now, what brings you quality of life? What do you have to be able to do in your life to feel that joy? What information do you need, and how do you want to receive it? What's a good day look like? You know, what's a win for you? And then what worries you the most? What brings you the most anxiety about this treatment? So common barriers, gosh, the list can go on and on. Healthcare literacy gaps. Are we using the words that they understand? You know, what does that look like? Do we draw really nice diagrams like she did? You know, written summaries. What will work for them? And then validating, you know, making sure they know we're on this journey with them. We are their big cheerleaders. We're there for the long haul, and we know it's scary. Family conflict about treatment. Boy, any of you ever sat in the room when, you know, someone wants to stop treatment or change treatment, and the caregiver or the loved one is not ready for that? So, and then there's patients that really distrust the medical field, and I'll be honest, in Indiana, we have a lot of rural area, and sometimes transportation is a big deal. Patients can't necessarily get into our office, you know, as many times as we would like for them to do. So making sure that we're utilizing social services, you know, our social work team, all of that to make that better. Okay, barriers, any barriers that we didn't cover that y'all want to shout out, or you two? No?
I believe that they
gosh.
really incorporated
videos
everything
keep
that I had to say, how I felt. Everything was explained to me. My two sisters and my daughter were all there together. after I had my bone marrow, and it did this diagram, and they asked me what I wanted to do, gave me the options. I feel like I was very involved in it. My quality of life, my independence, all of that was discussed. I feel like my quality of life has really increased. I always feel very comfortable asking questions, or if I have any concerns. Sometimes if I have something for the research nurse, I can text her, she'll text me back. I get on my chart, I'll send an email over to Selena and she'll respond right back. I have no issues asking any kind of questions. Honestly, I can say that there's not anything my care team could have done better to support me in decisions. They are so hands-on.
And shout out to her dog who's been there to support her.
That's right.
Also part of her support system.
Key takeaways, just to kind of pull it all together. Remembering the importance of the risk stratification. So really individualizing the patient, understanding their MDS, their molecular biomarkers, all of that, so that can drive the treatment. Luspatercept and imetelstat have defined anemia management in this low-risk MDS population, know what to monitor at each visit, and stay alert for the prognostic markers. And anticipate, assess, act, and adapt if a patient has a toxicity, an adverse event, and do everything we can to mitigate those and maximize their quality of life. And then making sure that the patient is part of the decision making, that we're really listening to what's important to them and to what would bring them some peace about where they are in the disease continuum. Here are some resources that are fabulous that you can take a picture of. Or
It's also, I think this should be in your handout.
Oh, good. Okay. All right. And post-test time. I swear this is it. Okay. So post-test question. Are low-risk MDS anemia and residual thrombocytopenia from prior treatment. He wants to minimize time away from work, but is worried about fatigue. Which strategy demonstrates shared decision-making? Explore trade-off between treatment schedules, prioritize a therapy, recommend a treatment with low risk of thrombocytopenia, or select therapy with the longest expected duration of response. I can't read. Oh, yeah. Explore trade-offs between treatment schedules. Yes. Potential cytopenias.
This is a tricky one. They're all a little right.
Yeah. We talked about how they could all actually be right in certain patients. Okay? Any last minute questions? Thank you. We didn't mean to go over. You just have had some really good questions and some really good dialogue, so I appreciate it.
Yes, I want to thank you all for participating. I think everyone on the panel, and again, sorry for going over. Appreciate your being here and participating. I just want to make sure you get your credit for sitting here. Please scan the QR code or visit mli.link/26ons-DPA. And I think it might be on the screen. And again, thank you so much, and we appreciate any feedback, and thank you all.